me someone. Have you ever shared?
Hello again, I'm Dr. Hung Vu in our show is America's Healthcare Crisis. The title for our show tonight is Leadership in Organized Medicine Part 2. And I'm very happy to invite Dr. John Granato back to continue with our conversation about organized medicine. John, during the last show, I was asking you about the quality of leadership, and you said that you believe that we have very good leadership in medicine. Now, on the other hand, the statistics show that up to 40% of physicians are burning out for one reason or another. What can organized medicine do to help them, or at least to provide a nurturing environment so that doesn't happen?
Well, it's a very difficult issue to address. I certainly agree that organized medicine should be making some effort to assist physicians who are having difficulty. But in fact, the resources for organized medicine are limited, and it takes resources to provide assistance. I think that organized medicine is certainly striving to have physicians understand that the primary goal of their efforts should be directed toward the patient, that the patient should be the center of healthcare. Of course, it's very difficult for physicians to keep that in the forefront when they're facing grave economic difficulties. And there are physicians who are facing difficulties economically and otherwise. Many physicians feel that they've lost their autonomy in the practice of medicine because they're seeing fewer patients, and for many physicians, their sense of worth, of the value of what they do is determined by the volume of patients they see. And if a physician is sitting in his or her office twiddling their thumbs, it's very difficult to think of yourself as making a valuable contribution to society. I think organized medicine does need to make some effort to help physicians make a transition, either to other areas of practice or even other types of careers. It's a difficult thing to accomplish, but I agree that more needs to be done.
Now you say that there's limited resources to help physicians. I mean, how is organized medicine financed? It's just through membership contributions only?
Well, certainly on the county and state level, that is true. At the national level, the AMA does have a significant amount of non-dues income. But for both the California Medical Association and the county societies, that's not true. They are dependent almost totally on their dues income. And for instance, at the present time, we are really gearing up for another medical liability insurance crisis. The trial lawyers are going to make a determined effort to get a ballot initiative that will overturn the MICRA caps. MICRA being the law that was passed that limits recovery for non-economic damages, and I want to stress that. The limit only refers to non-economic damages. And that will take a very significant amount of money to counteract the efforts of the trial attorneys. And that may even result in a dues assessment for members of the association. One of the publications in the Washington, D.C. area, Roll Call, recently recognized the AMA as one of the 10 most effective advocacy groups in the United States. And certainly CMA, California Medical Association, has been very successful on behalf of patients and physicians in their legislative efforts. Takes money to do that, takes lots of money because there are a lot of competing interests. And repeatedly, the members of the association have registered advocacy, political advocacy, as their number one concern.
Yeah, it's interesting that you mentioned money. You know, I would say money and leadership. Sometimes money and leadership is not synonymous. And as a country, I'm afraid that the sayings that money talks, you know, and I don't necessarily agree with that. You know, there are people who don't have any money at all, but what they say is very far-reaching. You know, Mother Teresa is one. Who else? I don't kind of think of somebody else, but you know, I mean, to me, from my own viewpoint, coming from a faraway country, you know, I think that money can be effective and helpful, but you know, it's I think it's tend to be overemphasized in the making of politics in this country, especially when I talk about medicine, which is for me still a noble calling. You know, if you don't have money, you use other things to fight, you know, or to present your case effectively. Now, you're mentioning the threat of malpractice and the trial lawyers. It's so true, because especially now that we are approaching the so-called managed care system, physicians have to churn patients out at the rate of 5, 6, 10 minutes per patient. You know, I mean, inevitably there are going to be more errors. There's going to be more mistakes and more unfavorable outcome. And what is organized medicine doing about preventing that before it goes to a case in a court?
Well, CMA, California Medical Association, has been very active legislatively to assure that physicians are not coerced by managed care organizations into providing substandard care for patients. And they have been successful. They have unilaterally published data on medical loss. That is, the amount of the premium dollar collected by an insurer that actually goes to providing care as opposed to administrative overhead. The CMA sponsored a bill that would have had a state agency do that, and unfortunately that bill did not receive approval, but CMA is doing that on their own. They have also sponsored legislation that provides avenue of relief for physicians who are terminated without cause from managed care organizations for the types of activity that you're referring to.
You know, I personally know of physicians who have been fired at will, you know. And again, you know, it's very easy to dismiss a physician now because there's a glut in providers. So a lot of employers or organizations are very callous about dismissing a physician for no reason at all. Sometimes there's no worthy reason. And my understanding is that even if that physician is a member of organized medicine, he doesn't have much of a chance to go to the body to ask for help. I mean, some of the physicians told me that the best they could have is a referral to a lawyer. That's it.
Well, you know, again, from a practical perspective, it's not possible to provide legal representation to every CMA member. However, CMA has been very active in that arena. There was recently resolved what became a very famous case called the Martel case, which involved physicians in Sacramento who were induced to join a managed care organization. These happened to be ophthalmologists. They were brothers, and they had a large practice most of which involved poor patients. And shortly after they had agreed to provide care under this managed care organization, they were terminated. The organization obviously used their names to...
Why were they terminated?
Without cause. Without cause. Okay.
The HMO boss didn't like them.
Well, you know, they used their names to entice patients to join their managed care organization.
Oh, I see.
And then once the patients had switched, they terminated their contract with these physicians. And recently, there was a favorable ruling in favor of those physicians.
Okay.
And CMA was very active. They actually provided money for legal defense and provided amicus curiae briefs in support of those physicians. So CMA has been very active in that arena.
Well, I'm not really talking about legal defense on money. You know, I'm talking about giving guidance, giving counseling, giving some support for the physicians in need.
CMA has been very active in that area as well. There is a manual that is available to both CMA members and non-members that prescribes very clearly how to deal with notices of termination from managed care entities. You know, what steps to take, types of letters, samples of letters to write, things to inquire about. You know, unfortunately, in our country, many of these issues, the ultimate resolution is a legal resolution. For better or worse, that's the way things are in our country at this point in time.
I realize that, you know, but I'm just saying that there's the way to prevent problems from becoming a legal issue to begin with is to provide a nurturing environment where physicians can practice quality medical care and achieving their mission without any kind of unfair or undue hardship, which I mean, we're talking about 40% of physicians are burning out. I mean, that's frightening. You know, my understanding is that as a profession, physicians are ranking high in terms of suicide, divorce, chemical dependency. And when you think about the fact that they have to take care of patients, I mean, you wonder how they can do that if they don't know how to take care of themselves. And to me, it must be the result of a system that somehow has not been able to prevent that from happening in the first place. I'm talking about like the way we go through medical school and training. It's really a highly competitive, aggressive environment. And in that kind of environment, it's easy to be burned out. I mean, you don't have a nurturing, cooperative kind of atmosphere when you can congenially help each other to take care of patients.
Well, you know, there's no doubt about it that by and large, physicians are very competitive individuals, both individually and as members of organizations and medical staffs. And that certainly may be a contributing factor to the types of conditions you've addressed, but it has also contributed to the great progress that American medicine has made. I mean, you know, I think people all over the world acknowledge American medicine as the best in the world.
Technology, not otherwise.
Well, you know, in terms of outcomes, I don't think anyone has achieved the outcomes that American medicine has achieved. And you may well differentiate technological achievement from humanism, and I think that that's certainly a valid concern. And I think one of the driving factors in the effort to increase the number of primary care physicians is to satisfy patient need for a more humanistic, less industrial approach to care. Countervailing that is managed care, which is striving to interject more industrialization, if you will, into the provision of care. There are many competing influences. And, you know, I would be the first to admit that the termination without cause issue, for instance, is not limited to only managed care organizations. There are certainly physician organizations, IPAs, that would be loath to see that ability disappear because they feel that as an entity, in order to survive, they can't afford to have more physicians providing care than they actually need to provide care. So it's a many-faceted issue.
Right, right. Now, actually, I have to take issue with the fact that you said you went blind, that we have a better outcome in our country. All depends on how you see it. Interestingly, I did a comparative study of the different systems of the developed countries. Germany, England, Italy, France, Canada, and particularly Japan. And it is clear to me that we spend way too much money for what we get. And the only place where we are superior to them, especially compared to Japan, is technology. For example, in a very poor, underdeveloped countries, the mortality is largely related to infectious processes. And in this country, I don't think it's directly related to antibiotics or any kind of medical device, but it's more related to public health issues. We have better water, better living conditions. You know, it's just that we have a cleaner environment, and that, in a sense, it's probably unrelated to what we're doing every day in terms of practicing. On the other hand, our mortality is largely related to cardiovascular diseases and cancers and accidents, which were all very minimal in other countries, especially underdeveloped countries. If you talk about Africa, heart attacks is rare. I mean, there you have different kind of pathology. You have a lot of rheumatic heart diseases, but MI belongs to the upper class who overfed themselves. Now, cancer is also very rare because their way of life is very close to nature. So in that sense, I would argue that we don't have a good preventive system in our country to prevent those diseases from happening to begin with. And if we do, then again, I think that if you combine both technology and cure, which is rare, once you have a massive heart attack or have cancer, no technology can help a patient anymore. And if you combine some of the great technological advances we have with good prevention, then I would agree that we have a good system. But already we're spending, $1 trillion, which is 15% of GNP. And I don't know if we're doing that good a job yet for the money we spend.
Well, there are certainly people who would agree with you, but people who would also disagree with you, who would say that spending 14 or 15% of the gross national product is not excessive, and that, maybe we ought to be spending more of the gross national product. And
not when it goes to the CEO. I mean, the CEO makes $1.2 billion.
We have no disagreement there. You and I have absolutely no disagreement there. But I'm talking in the aggregate. But you raise a number of important issues. Certainly, lifestyle contributes a great deal to many of the illnesses that we experience as Americans. And not enough attention has been directed in that regard. The other issue is that for many years, the hospital has been the center of health care, so that in effect, we are providing health care after the fact, when people have already been injured. And I think that is one of the potential advantages of managed care, to extend care across the continuum of care, not just in the hospital, but in the outpatient arena, and to address some of the issues that you've reasonably raised, so that there is more education done about lifestyle issues, about healthy lifestyles, about things like excessive abuse of alcohol, tobacco, speed.
Not only that, the cynic's view is that it is not in the interest of medicine to prevent, because they won't make any money if people are not sick. You see, I mean, if a person, has a healthy lifestyle to begin with, doesn't have a heart attack, the cardiovascular surgeon will be out of a job. The companies that manufacture those devices will be not making any money at all. So, I mean, the stimulus for economic incentive is not in prevention.
Well, that is a cynical view. That doesn't mean it doesn't have some validity, but it is a cynical view. However, one of the efforts to change that has been the use of capitation, which is something that is disliked by many physicians for many reasons, some of which are valid. That one of them being that individual capitation, which I don't think is capitating an individual physician for an individual patient can ever really be justified. But you're right, we need to create incentives for physicians to become more involved in care outside of the hospital in a preventive vein.
Right.
And I think we're moving in that direction.
Okay. Let me ask you, we have 650,000 physicians in this country. And it's a very well-known fact that physicians as a group is very divided. How is organized medicine, how is the leadership of organized medicine going to unite physicians under the same banner? We have a mission, a very lofty mission, but if physicians are so divided, how can we achieve anything?
Well, you raise a very good issue. But there are efforts being made, both at the state level and at the national level. CMA and AMA have created new modes of representation for physicians to attract physicians who may feel that they have not been represented. Up until the last 5 years, most representation has been geographic representation. I live and practice in Santa Clara County. Delegates are elected from Santa Clara County and provide leadership and representative governance. However, it may be difficult for a physician who is in a group practice to represent someone who is in a solo practice and vice versa. And to counteract that, both the CMA and the AMA have initiated efforts to provide representation based on an individual's mode of practice. That is a solo practice or a group practice, a small group or a large group or a very large group. In addition, there has been recognition that ethnicity is a comfort for people, and that certain physicians would rather be represented as a member of a particular ethnic group. And they have created forums to allow that type of representation as well. So organized medicine is making an effort to reach out to involve more physicians in more ways in organized medicine, so that they can provide a unity and a better representation for everyone and a better representation for patients.
I understand that there was a decrease in membership. How much of a decrease is that during the last several years, and why is that so, and what can we do to prevent membership from eroding further?
There has been a very slow but steady decline in membership. And there has been debate back and forth as to what's caused that. One view has been that it is purely economic, that as physicians have been hammered by decreasing reimbursement, that they have been less willing to spend the money for membership in organized medicine. There are other people who feel that organized medicine has not provided what the physicians have perceived as value for the money that they've spent. There's probably some truth in both of those areas. I think that we will see no significant, or perhaps not any, increases in dues for membership in organized medicine, and we may even see some dues reductions. In addition, the organized medicine is attempting to find ways to make membership more valuable for physicians. One of the things that CMA has done is to create a quality institute whose goal is to help physicians with things like protocols and practice guidelines, and to devise means of measuring quality so that physicians can better represent their achievements.
Okay. Thank you, John. It's been a very
Pleasure.
Informative
Again,
and
thank
enjoyable.
you very much for asking me. It's
And
a privilege.
this is Dr. Vu. You're just listening to Dr. John Granato, a neurologist who has been active in many facets of organized medicine, giving us some very valuable information on how organized medicine in this country is working or not working. I'm Dr. Vu. Our show is America's Healthcare Crisis. Thank you for watching. See you next time.
Have you ever
Good night.
Do you need someone to always be there when you feel lonesome and deep in despair? Do you need someone to dry up your tears? Do you need someone to always be near? Do you have someone to stay through the years? Let me be the one now that I am here. Let me be the one to be there with you through the